This is a presentation on osteomyelitis by Brianna, Cole, Sammy, Andrew, and Grace.
Osteomyelitis is inflammation of the bone, often resulting in resorption. Inflammation can spread to bone and their surrounding areas. Osteomyelitis often occurs in two different phases, acute and chronic. Acute inflammation of the bone is often due to odontogenic etiology, or inflammation caused by a physical injury. Chronic inflammation is often due to persistent, untreated, or inadequately treated acute osteomyelitis. Increased risk of osteomyelitis occurs in patients with immunosuppressive states, cancer, chemotherapy, HIV, AIDS, systemic diseases like diabetes mellitus with impaired neutrophil function, and decreased vascularity disorders such as radiation therapy, late-stage Paget's disease, osteopetrosis, late-stage florid cemento-osseous dysplasia, bisphosphonate therapy for osteoporosis or metastatic cancers.
The clinical findings of osteomyelitis are nonspecific symptoms typical of an infection, with periods of exacerbation and resolution. There can be jaw involvement in up to 1/5 of cases. The symptoms include things like fever, leukocytosis, lymphadenopathy, and pain and tenderness in the area, which can include the lower back if there's spine involvement. There's swelling, paresthesia, general discomfort or ill feeling. Nausea is possible secondary to the infection. There can be a change in range of motion in some joints, discharge, pus, and sinus tracts, or loose teeth. Keep in mind that it can be difficult to identify any of these symptoms.
Radiographic findings of acute osteomyelitis include radiolucent defects with decreased bone density, lytic and sclerotic changes to bone, periosteal bone formation due to the inflammation, most often seen in the mandible, with poorly defined gradual transition to normal bone, and oftentimes necrotic bone. Chronic osteomyelitis is also most often seen in the mandible, with mixed radiolucent and radiopacities. There is an increased osteoblastic activity with more periosteal bone formation appearing like onion skin layers. There is sclerotic radiopaque bone internally with scattered radiolucencies internally. You will also see more necrotic bone with widened PDLs of adjacent non-vital teeth. In Figure 3, we see a pantomograph showing chronic osteomyelitis of the left mandible. We see a circular lesion with mixed radiolucency and cortical bone resorption. In Figures 4 and 5, we see a cone beam CT of a patient with acute osteomyelitis following a dental extraction. Figure 6 shows osteomyelitis as a complication of florid cemento-osseous dysplasia. The panoramic image shows mixed radiolucent and radiopaque cotton wool appearance in the left mandible. The axial CT shows corticated borders with a radiolucent rim of the lytic lesion. The 3D CT image shows bony changes of the left mandible. The solid arrow points to the osteomyelitic lesion.
The differential interpretation for acute osteomyelitis includes some of its clinical features of paresthesia and pain and percussion sensitivity. For paresthesia, it must be distinguished from a malignant neoplasm, which you would do using a radiograph or a biopsy. Pain and percussion sensitivity may be confused with a periapical abscess or cyst, so that must be differentiated from acute osteomyelitis on the radiographic appearance. The radiographic features of acute osteomyelitis would not have to be distinguished from any other pathology because there are probably no signs on the radiograph of the infection. Signs and symptoms may appear without anything on the radiograph, so to rule out other pathologies, including periapical and malignant neoplasms, a CBCT may be necessary. The histologic features of chronic osteomyelitis must be differentiated from fibrous dysplasia and ossifying fibroma. All of those will show chronic inflammatory cells in fibrous marrow spaces on biopsy. However, chronic osteomyelitis will show osteoblasts and osteoclastic activity and irregular bony trabeculae, which is characteristic for chronic osteomyelitis. The clinical features of chronic osteomyelitis include swelling, draining tracts, and pus, and this must be differentiated from a periapical abscess clinically. This can be done using the radiographic appearance. On the radiograph, chronic osteomyelitis will show a moth-eaten appearance, diffuse borders, and osteosclerotic changes. This appearance on the radiograph must be distinguished from the carcinoma of maxillary sinus or squamous cell carcinoma, Ewing sarcoma, or fibrosarcoma, and these can all be accomplished through a biopsy.
Treatment of acute osteomyelitis involves removing the source of infection. This includes antibiotics, drainage establishment, and treating the tooth, either through extraction or endodontic therapy. Chronic osteomyelitis may be treated through surgical intervention depending on the severity of the infection. Hyperbaric oxygen can also be used in conjunction. Antibiotic therapy involves the biopsy of the infected bone to allow proper antibiotic selection against the agent. Microbial culture and susceptibility results may be required. If we are unable to perform this biopsy, broad-spectrum empiric antibiotics should be used. IV antibiotic delivery can be for 6 weeks, and additional oral antibiotics can be used if the infection is more serious. Surgery indications include antibiotic failure, infected surgical hardware, or chronic osteomyelitis with necrotic bone and soft tissue. The foreign objects must be debribed, blood flow must be restored either through bone or tissue graft, or amputation must be performed. Osteomyelitis is difficult to cure and has a high relapse rate despite combination treatment. 20 to 30% recurrence rate occurs with severe morbidity and mortality. Higher recurrence is expected in patients with vascular disease or diabetes. Increased risk factors for developing post-traumatic osteomyelitis include elderly, intraoperative blood transfusions, or infection. Our references include the following. Our image citations include the following.